Immunity in Health and Diseases, Immunodeficiency, Part 1. Immunodeficiency is the condition in which immune system is not able to mount on an effective immune response against an antigen. The immune system's ability to fight a pathogen is compromised or entirely absent. This can lead to repeated microbial infections of varying severity. Sometimes it has been seen that the patient can develop enhanced susceptibility to malignancies as well. A person suffering from immunodeficiency is said to be immunocompromised. Such an individual is susceptible to opportunistic infections in addition to normal infections that could affect everyone. There also seems to be a relationship between persons suffering from immunodeficiency and also having autoimmunity through perpetual immune system activation. The severity of the immunodeficiency disease is also dependent on the number of components of immune system getting affected. For example, in certain disorders, there is a deficiency of specific immunoglobulin, mostly IgA or IgG. However, in certain cases like SCID, severe combined immune deficiency, multiple components of immune system are affected, and this can also cause death. The history of immunodeficiency disease is interlinked with advances in the field of clinical physiology, microbiology, pathology, along with experimental immunology. However, the first case of immunodeficiency may be defined as the one in a strain of guinea pig in 1990 by Muir at the Vermont Agricultural Station in Burlington. It was an autosomal recessive disorder with deficiency of a particular serum protein that was later established as C4 protein. The same defect was later found in a colony of outbred Hurley guinea pigs at National Institute of Health. With newer techniques, almost all deficiencies of complement component regulators and receptors could be characterized. Although during half-life of 20th century, many patients with typical symptoms of immunodeficiency disorders such as complement deficiency, neutropenia, ataxia, telangiectasia, mucocutaneous candidiasis, then Wiskott-Aldrich syndrome has been reported. The beginning of immunodeficiency is generally considered as 1952 when Ogden Burton reported the first case of A gamma globulinemia. The discovery of A gamma globulinemia by Ogden Carr Burton is regarded as the earliest breakthrough of immunodeficiency disorders. In fact, the disorder has been named after him as Burton type A gamma globulinemia. Not only was Dr. Burton responsible for the discovery, he is also credited for finding a specific immunotherapy for this X-linked disorder in the form of intramuscular injections of IgG immunoglobulin. After the first report of X-linked A gamma globulinemia in 1952, nearly 150 different types of immunodeficiency disorders have been identified. X-linked A gamma globulinemia in 1952, nearly 150 different types of immunodeficiency disorders have been identified. The discovery of immunodeficiency disorders and the molecular characterization of these diseases paved the way for better understanding of organization of immune system. This further led to better immunological diagnostic methods or techniques, which led to early detection and better treatment. Classification of immunodeficiency disorders. Immunodeficiency could be due to certain inherited factors, drugs, or certain medical or physiological conditions like infections, pregnancy, aging, or due to numerous other factors. Based on different criteria, these diseases have been variously classified. The most common classification deals with the origin of the causes of immunodeficiency that could either are in immune system or there are involvement of some existing factor causing the disease. Accordingly, they have been categorized as preliminary immunodeficiencies. They are the inherited defects of the immune system. They result from genetic or developmental defects of the immune system. Mostly the defect is present at birth, though it may not manifest itself at the time of birth. Primary immunodeficiencies are also called congenital immunodeficiencies. Secondary immunodeficiencies. Wait a minute. Primary immunodeficiencies, they are inherited defects. Mostly the defect is present at birth and they result from genetic or developmental defects of the immune system. Then mostly the defect is present at birth, although it may not manifest itself at the time of birth. Primary immunodeficiencies are also called congenital immunodeficiencies. Then secondary immunodeficiencies, they are the defects that arise due to certain extrinsic factors like drugs or minerals, malnutrition, or certain infections. The most common being AIDS or acquired immunodeficiency syndrome due to infections with the human immunodeficiency virus 1 HIV 1. Alternatively, the immunodeficiency disorders are also classified as specific immunodeficiency disorders. These are those disorders in which the specific component of the immune system responsible for the condition is non-food, like abnormalities of B and T cells. Non-specific immunodeficiency disorders. The abnormalities of non-specific components of immune system are responsible for these disorders. Secondary immunodeficiencies, they are the defects that arise due to certain extrinsic factors like drugs or minerals, malnutrition, or certain infections. The most common being AIDS or acquired immunodeficiency syndrome due to infection with human immunodeficiency virus. Alternatively, the immunodeficiency disorders are also classified as specific immunodeficiency disorder. These are those disorders in which the specific component of the immune system responsible for the condition is non-food, like abnormalities of B and T cells. Then non-specific immunodeficiency disorders. The the abnormalities of non-specific components of immune system are responsible for these disorders. It has been seen that in primary immunodeficiency disorders, defects may perhaps be specific or non-specific type. Sometimes the immunodeficiency disorders are also characterized based on the component that is affected. Humoral immune deficiency. B lymphocytes, plasma cells, or antibodies mostly accompanied with hypogammaglobulinemia. Example, chronic lymphoid leukemia, multiple myeloma. Then T cell deficiency, T lymphocytes affected components. Then secondary disorders such as acquired immune deficiency syndrome. AIDS. Then neutropenia, neutrophils, chronic granulomatous disease. Then asplenia, impaired or no function of spleen. Splenectomy, sickle cell anemia. And complement deficiency, deficiency of complement components, congenital deficiencies. Primary immunodeficiency diseases, PID. Primary immunodeficiencies involve abnormal development of immune system. It can be due to impaired innate or adaptive immune system. Deficiencies involving adaptive immunity could be due to deficient B cell system or deficient T cell system, or both, as they are considerable overlapping between the two, as any deficiency of T cell helper cell or T suppressor T cell will directly affect antibody synthesis. In most cases, primary immunodeficiency disorders are found to be inherited single gene disorders occurring in infancy or early childhood. However, they can also be present in grown up children, pubescent, and adults. At times, they can be associated with relatively mild clinical manifestations in some patients, with 70% of patients being male. PIDs show a clear gender bias. This is due to X-linked inheritance of some syndromes. Also, 50% of defects are those related to B cells. T cell defects account for 30%, 80% belonging to deficiencies in phagocytes, and 2% belong to complement deficiencies. The frequency of PIDs has been found to be around 1 raised to 10 individuals. Primary immunodeficiencies are further classified as under humoral immunodeficiencies, B cell defects, cellular immunodeficiency, T cell defect, combined immunodeficiency, B and T cell defect. Disorders of complement, disorders of phagocytosis. In this chapter, we will be discussing the first three types of primary immunodeficiencies, while disorders of complement system and disorders of phagocytosis along with secondary immunodeficiencies could be discussed in the next chapter. Humoral immunodeficiencies, B cell defects. B cell immunodeficiencies could involve complete deficiency of mature recirculating B cells, plasma cells, and immunoglobulin, or absence of a particular class of immunoglobulin. Some of the common diseases of the type are X-linked agammaglobulinemia, transient hypogammaglobulinemia of infancy, common variable immunodeficiency or late onset hypogammaglobulinemia, selective immunoglobulin deficiency, IgA, IgM, or IgG subclasses, immunodeficiencies with hyper IgM, then transcobalamin 2 deficiency. X-linked agammaglobulinemia, also called X-linked hypogammaglobulinemia, XLA, Bruton type agammaglobulinemia, X-linked agammaglobulinemia or Bruton syndrome. The diseases was first elucidated by Ogden Carberton in 1952. It is a rare X-linked genetic disorder that involves mutations in the gene coding for Bruton tyrosine kinase BTK. So BTK is very important for the maturation of pre-B cells to differentiate mature B cells. All classes of immunoglobulins are depleted in the serum of patient. So BTK gene is present on X chromosome and therefore the defect is inherited as X-linked recessive and is almost always limited to the sons of female carriers, later being asymptomatic all their lives. The symptoms of XLA include repeated and often severe infections accompanied with ear infections, sinusitis, diarrhea due to giardia, and pneumonia. The most common pyogenic bacteria responsible for infection is HLA are Streptococcus, Staphylococcus, and Haemophilus. The treatment involves immunoglobulin replacement therapy or intravenous introduction of mixture of immunoglobulin, IVIG, human IgG antibodies on a regular basis for life. Unaffected carrier father, unaffected carrier mother, unaffected 1 in 4 chance, unaffected carrier 2 in 4 chance, unaffected 1 in 4 chance. Unaffected carriers are 2. Okay. Inheritance pattern of XLA. Transient hypogammaglobulinemia of infancy, TH1. The immune system in a newborn is not fully developed. Most of the immunoglobulins in neonates are those that were produced by the mother and transferred by the placenta before birth. These immunoglobulins provide protection to the neonates till they start producing their own, usually by age 6 months. So, most of the immunoglobulins in neonates are those that were produced by the mother and transferred by the placenta before birth. The immunoglobulins provide protection to the neonates till they start producing their own, usually at their age 6 months. Meanwhile, the levels of immunoglobulins from the mother also start decreasing. In infants with transient hypogammaglobulinemia of infancy, there is a delay in the production of normal amounts of immunoglobulins. This results in low levels of immunoglobulins at age 3 to 6 months and back to normal levels at about age 12 to 36 months. The disease may be present in infants of both sexes. Although the condition rarely leads to serious infections, but few infants develop respiratory or digestive tract infections. This disorder may last for few months to a few years but get resolved without treatment. Antibiotics are often prescribed to combat infections. Certain diseases have, however, suggested that THY may be an intrinsic B cell defect with abnormal antibody responses. Then common variable immunodeficiency, late onset hypogammaglobulinemia. CVID is one of the most common sympathetic primary immunodeficiency when the symptoms developed around 15 to 35 years of age. It is generally characterized by recurrent pyogenic infections accompanied by malabsorption and giardiasis. The level of immunoglobulins is less than 300 mg per ml. It has been seen that B cells are present at normal levels. However, there is a defect in their ability to differentiate into plasma cells and secrete immunoglobulins. It is accompanied with decreased T helper cells and activity and increased activity of T suppressor cells. Individuals with CVID are more prone to developing certain forms of cancer like lymphoma. The genetic causes of CVID are largely unknown. Through mutations in at least 5 genes have been associated with CVID. So these include inducible T cell co-stimulator ICOS along with some other proteins on B cells. The treatment involves intravenous infusion of immunoglobulin. Then selective immunoglobulin deficiency IgA, IgM or IgG subclass. SIGD is an inherited disorder when there is a selective deficiency of a class of immunoglobulin, while others remain normal or may be elevated in some cases. The most common form of selective deficiency is that of IgA. Most of the IgA in the body is in the seromucous secretions, including tears, saliva, colostrum, genital respiratory, and gastrointestinal secretions. It is a dimeric antibody that plays a major role in protecting us from infections in these areas. Though most of the patients do not show any symptoms, however, in some cases, they increase susceptibility to respiratory and gastrointestinal infections. In some patients, anti-IgA has also been detected. Allergies may also be common in these patients. It has been seen that some patients with IgA deficiency can also found to have IgG2 or other IgG4 subclass deficiency. In these patients, the common finding is a maturation defect in B cells to produce IgA. It is not currently possible to substitute IgA in patients suffering from IgA deficiency. Although scientists are currently working on purification of human IgA, the condition gets further aggravated with knowledge that IgA in the serum, unlike IgG, does not remain stable in the circulation for very long. Therefore, there is no effective treatment for this disorder, though antibiotics can be prescribed to combat infections. Selective IgM deficiency may also be found in some patients and is generally associated with septicemia. Immunodeficiencies with hyper IgM, HIGM syndrome. In this disorder, there are elevated levels of IgM and decreased levels of IgG, IgA, and IgE. The IgM are normal and have antibody activity. IgM is the form of pentameric antibody that all B cells produce initially before B cells go through the class switching due to exposure to an antigen. Is X-linked or autosomal recessive and is accompanied with impaired antibody class switching mechanism. Patients show enhanced susceptibility to infections along with thrombocytopenia, neutropenia, hemolytic anemia, and renal lesions. 5 types of HIGM have been characterized. Hyper IgM syndrome type 1 X-linked involves mutations of the CD40L gene. Signal from T cells to B cells for class switching is lacking. Hyper 1 IgM syndrome type 2 autosomal recessive involves mutations of the AICDA gene. Defection heavy chain production hinders class switching. Hyper IgM syndrome type 3 involves mutations of the CD40 gene. B cell not able to receive signal from T cells for class switching. Hyper IgM syndrome type 4 involves defect in class switching recombination downstream of the AICDA gene. Hyper IgM syndrome class 5 involves mutations of the UNG gene. Patients with all forms of HIGM syndrome have a severe IgG deficiency and they require immunoglobulin replacement therapy. Transcobalamin 2 deficiency. It is inherited as autosomal recessive disorder where there is deficiency of vitamin B12 along with megaloblastic anemia, scarcity of red blood cells, and abnormally large sized red blood cells that are remaining, and interstitial villus atrophy. So, transcobalamin 2 deficiency, it is inherited as autosomal recessive disorder where there is deficiency of vitamin B12 along with megaloblastic anemia, scarcity of red blood cells, and abnormally large sized red blood cells that are remaining, and intestinal villus atrophy. Transcobalamin 2 is a protein that is actually responsible for transporting vitamin B12 to tissues from GI tract. So transcobalamin 2 is a protein that is actually responsible for transporting vitamin B12 to tissues from GI tract. And cobalamin or vitamin B12 is obtained from the diet and is found in animal products such as meat, eggs, and shellfish. The absence of cobalamin leads to impaired growth, a shortage of blood cells, hypogammaglobulinemia, and other symptoms. Those become apparent within the first weeks or months of life. Neurological function is compromised in such individuals and they suffer from progressive inflexibility and weakness in their legs. Paraparesis, muscle twitches, myoclonus, or intellectual disability. Treatment with vitamin B12 can help in restoration of hematopoietic gastrointestinal, and B cell functions. Cellular immunodeficiencies, T cell defects. T cell play a very vital role in immune system. Therefore, any deficiency in T cell would directly affect both humoral and as well as cell mediated immunity. This further leads to increased susceptibility to viral, protozoan, and fungal infections. Most common intracellular pathogens such as mycobacteria, pneumocystis carinii, and Candida albicans have been found to be thriving in such cases and showing the importance of T cell in eliminating this pathogen. Some of the most common T cell immunodeficiency defects as follows: thymic hypoplasia, chronic mucocutaneous candidiasis, purine nucleoside phosphorylase deficiency, thymic hypoplasia. So we're learning about types. Hyper IgM syndrome type 1, X-linked. Hyper IgM type 2, syndrome type 2. Hyper IgM syndrome type 3. Hyper IgM syndrome type 4. Hyper IgM syndrome type 5 involves mutations of the UNG gene. Patients with all forms of HIGM syndrome have a severe IgG deficiency and they require immunoglobulin replacement therapy. Transcobalamin 2 deficiency. It is inherited as autosomal recessive disorders where there is deficiency of vitamin B12 along with megaloblastic anemia, scarcity of red blood cells, and abnormally large sized red blood cells that are remaining, and interstitial Wills atrophy. Cellular immunodeficiencies, T cell defects. T cells play a very vital role in immune system. Therefore, any deficiency in T cell would directly affect both the humoral as well as cell mediated immunity. This further leads to increased susceptibility to viral, protozoan, and fungal infections. Most cellular intracellular pathogens such as Mycobacterium, Pneumocystis carinii, and Candida albicans have been found to be thriving in such cases, hence showing the importance of T cells in eliminating these pathogens. Some of the most common T cell immunodeficiency defects are as follows: thymic hypoplasia, chronic mucocutaneous candidiasis, purine nucleoside phosphorylase deficiency, thymic hypoplasia, DiGeorge syndrome, 22q11.2 deletion syndrome, Swinson syndrome, velocardiofacial syndrome, Takau syndrome, conotruncal anomaly phase syndrome, CTAF, and Sedalkova syndrome, cardiofacial syndrome, congenital thymic aplasia, thymic hypoplasia, strong syndromes, TGS. It is a microdeletion syndrome involving deletion of a small segment on one copy of chromosome 22. The inheritance pattern is autosomal dominant and the ratio at which it is prevalent is about 1:4 100% in a general population. About 90% are de novo. The deletion of genes from chromosome 22 usually occurs as a random event in the father's sperm or in the mother's egg, or it may occur early during fetal development. Rest are inherited from a parent. The syndrome was described in the endocrinology Angelo DiGeorge in 1968. The exact mechanism that is responsible for features of the disease are unknown. Of all the deleted genes, about 30 to 50, some have been identified as possibly playing a pivotal role in the development of some of the signs and symptoms of the disease. TBX1 is a part of T-box family of genes that play an important role in tissue and organ formation during embryonic development. In DGs, point mutation in this gene has multiple effects including abnormal development of endodermal derivatives of third and fourth pharyngeal pouches, leading to aplasia or hypoplasia of thymus and parathyroid glands. Since thymus is involved in the development of T cell cellular immunity, patients with TGS are highly susceptible to intracellular pathogens. They also seem to be more prone to get Parkinson's disease. The syndrome is also known as CATCH22, where 22 stands for abnormality in chromosome 22 and CATCH for following features: C for cardiac abnormality, interrupted aortic arch, truncus arteriosus, and tetralogy of Fallot, abnormal face, thymic aplasia, cleft palate, hypokalemia and hypoparathyroidism. Don't forget, we are talking about T cell defects. Thymic hypoplasia. The FISH, fluorescent in situ hybridization test, has made the diagnosis of DGS more precise and more common. No effective cure has been found for this syndrome. Through transplantation of thymus can be done in case of a rare case where there is complete lack of thymic tissue called complete DiGeorge syndrome. Repeated bacterial infections are treated with antibiotics, while cardiac surgery can be done to correct congenital heart abnormalities. Hypocalcemia due to hypoparathyroidism can be treated with lifelong vitamin D with calcium supplements. Then chronic mucocutaneous candidiasis. It is a heterogeneous disorder in impaired cell-mediated immunity against Candida species. The inheritance of this case has been found to be autosomal dominant, whereas there is a mutation in the signal transducer and activation of transcription 1 gene, or it is recessive in some cases involving a mutation in the autoimmune regulator gene. In many cases, T cells completely fail to recognize the antigen. Patients develop candidiasis of mucosa, nail, and skin. Antifungal are useful to control the disease. Purinucleoside phosphorylase deficiency. It is also called PNP deficiency and is a rare autosomal recessive disorder that causes decreased cell-mediated immunity along with recurrent or chronic infections. The disorder is due to mutation in purinucleoside phosphorylase gene that is located at chromosome 14q13.1. Enzyme PNP is involved in sequential degradation of purines to hypoxanthine and then to uric acid. Absence of PNP leads to building up of such metabolites in the cell that are particularly toxic to immature lymphoid cells, leading to lymphopenia and impaired cell-mediated immunity. Diagnosis can therefore be done by checking the uric acid levels in the patients. Combined immunodeficiencies BNT defects. The combined immunodeficiencies of both the humoral and cell-mediated branches are the worst of all the immunodeficiency disorders involving multiple components of the immune system. Some important disorders that belong to this category are Nesloff syndrome, ataxia, Lewis-Barr syndrome, Wiskott-Ulrich syndrome, severe combined immunodeficiency. Nesloff syndrome, cellular immunodeficiency with abnormal immunoglobulin synthesis. It is an autosomal recessive genetic disorder affecting both males and females. The condition is characterized by absent T cell function and varying degree of deficiency of B cell mediated immunity. Patients generally have progressively severe, recurrent, and eventually fatal infections. It is generally accompanied with thymic dysplasia. Despite the normal presence of immunoglobulin and antigenic stimulus doesn't induce antibody formation. Treatment include monthly injections of gamma globulin or combinations of fresh frozen plasma and heavy use of antibiotics to fight infection. Then ataxia telangiecta or Lewis-Barr syndrome. It is an autoimmune recessive genetic disorder. Both parents must provide a copy of a non-working gene to the child to develop this disorder. The combined immunodeficiency in this case is it is an autosomal recessive genetic disorder, so both parents must provide a copy of non-working gene to the child to develop this disorder. The combined immunodeficiency in this case is accompanied with cerebellar ataxia, means poor coordination, stands for small dilated blood vessels, ovarian dysgenesis, and chromosomal abnormalities. Generally, the survival rate is very low. Cell-mediated immunity is defective along with low levels of IgA and IgE. The disease is found to be progressive with symptoms of immunodeficiency along with neurological defects getting worse with time. Thymus transplants in fetus and transfer factor therapy are used to treat or control the symptoms. Some of the symptoms include decreased coordination of movements, ataxia, decreased mental development, discoloration of skin areas on exposure to sunlight, blood vessels are enlarged or dilated in skin of nose, ear, inside of the elbow and knee, and also in the whites of the skin. Eyes, jerky or abnormal eye movements, nystagmus late in the disease, sensitivity to radiation, including X-rays, and severe persistent respiratory infections. Here you could see ocular telangiectasia in person with ataxia telangiectasia. Wiskott-Ulrich syndrome. It is an X-rich recessive disorder characterized by eczema, thrombocytopenia, low platelet count, blood diarrhea secondary to the thrombocytopenia, and overall immunodeficiency. The syndrome is also called the eczema thrombocytopenia immunodeficiency syndrome, as eczema occurs in the first month of birth. Affected boys who rarely survive beyond 10 years due to recurrent infections, hemorrhage, or lymphoreticular malignancy. The female carriers are usually asymptomatic. The levels of serum IgM is very low, along with progressive deteriorating cell-mediated immunity. Treatment involved bone marrow transplant or transfer factor therapy. The syndrome is named after Dr. Robert Anderson Ulrich, who was an American pediatrician. He described the disease in a family of Dutch Americans in 1954. Severe combined immunodeficiency, also called lymphocytosis. Glanzmann-Reiniger syndrome. Severe mixed immunodeficiency syndrome and thymic eye lymphoplegia. The deficiency leads to numerous syndromes involving both cellular and humoral immune responses. SCID is considered to be most severe form of PIDs, also known as a bubble baby disease and bubble boy disease, well-known case of David Vetter, because its victims are severely vulnerable to infectious diseases. Infants with SCID have Infants with SCID have severe recurrent respiratory infections. Infections are generally serious and at times life-threatening. Other symptoms include poor growth, eczema, chronic diarrhea, etc. Bone marrow transplant is the only cure currently and routinely available for SCID, which provide a new immune system to the patient. In many cases of SCID, it has been found to be associated with X chromosomes, X-linked recessive, while in others it is transmitted by the autosomal or non-sex-linked recessive gene. Autosomal recessive, scientists have found at least 9 different non-genes in which mutations lead to the form of SCID. More recently, around 15 defective genes have been found to be responsible for SCID. X-linked severe combined deficiency, adenosine deaminase deficiency, purinucleoside phosphorylase deficiency, reticular dysgenesis, Omnen syndrome, Behr lymphocyte syndrome, JAK3, Artemis, DCL-REIC. Prognosis and prevention of primary immunodeficiency disease, PID. Most of the PIDs discussed above are genetic and generally lifelong. In many types of PID, the patients can lead a normal life if the condition is diagnosed early and effective treatment is given. It is known that delay in diagnosis leads to many complications or sometimes death in the patients with PIDs. In certain disorders, however, the prognosis is less optimistic and may require intensive care. Genetic counseling of prospective parents who also happen to be carriers can be an effective strategy of prevention of PIDs. Sex determination can also prevent incidence of X-linked disorders. Development of better screening tests for identification of PID is very common. Screening at genetic laboratories are not very common, very important. Screening at genetic laboratories as part of prenatal, neonatal, and carrier screening programs could be made mandatory, especially for females with a positive history. Also, specific programs may be designed for those who are planning marriages within relatives, as this increased frequency of PIDs. Management of primary immunodeficiency disease. Healthy lifestyle must be ensured for the patients of PID. They must be kept in infection-free environment and away from all sources of infections. Regular dental checkup is a must. Live vaccines are never given to patients suffering from PID. Killed vaccines may be used when required. All kinds of bacterial and fungal infections must be treated at the earliest. In some cases, continuous use of prophylactic antibodies may be appropriate. Antiviral therapy such as amantadine and tamantadine can be life-saving for the management of viral infections. Treatment may include monthly injections of gamma globulin or combinations of fresh frozen plasma and heavy use of antibiotics to fight infection. However, immunoglobulin replacement is contradicted in selective IgAD as serious anaphylactic reactions can be caused. The best treatment for T cell deficiency conditions is bone marrow transplant if a suitable donor can be found. Other treatment options may include treatment with cytokines or stem cell transplantation or cell gene therapy or thymic transplants. Now let's have a summary. Immunodeficiency disorders weaken the immune system ability to provide an effective defense to the body against pathogens or abnormal cells that attack it, such as bacteria, virus, fungi, parasites, and cancer cells, etc. Primary immunodeficiencies are those disorders in which body's immune system is either missing or does not have normal function. Almost all types of PIDs are genetic or congenital in nature. It has also been seen that men are more prone to get immunodeficiency disorders. In most cases, skin, respiratory systems, the ears, brain or spinal cord, or the urinary or gastrointestinal tract get affected. Heart defects are also seen in many patients. Many at time autoimmunity and malignancy are also associated with immunodeficiency. Depending on the type, some PIDs are so mild that they got unnoticed. However, some can be so severe that bone marrow transplant and stem cell transplant is the only cure. Patients suffering from skin generally die in infancy. However, research in PID is making great strides, and with efficient diagnosis and new treatment options, the life quality of infected individual is greatly enhanced.